Hello and welcome everybody. My name is Alexander Konopka from the Hamburg Center for Health Economics and the University Medical Center Hamburg-Eppendorf. I will guide you through our PECUNIA session. As the title of the session indicates, the primary aim of PECUNIA is to tackle the Tower of Babel that exists in the area of international estimation and comparison of healthcare costs. In this session, we will focus on those parts of the PECUNIA concept that tackles the internationally standardized identification and definition of services and resources in mental health care. We have 4 presentations. Judith Simon from the Medical University of Vienna will start with a presentation of the PECUNIA care atom and the general costing concept. Then I will talk about the PECUNIA concept of service identification, followed by Natasha Peric, also from the Medical University of Vienna, who will present findings from this identification task for Austria. And finally, Mencia Ruiz from the Universidad Loyola Andalusia will introduce you to the PECUNIA concept of service definition.
Welcome everyone to the first presentation of this session about the harmonized identification and definition of services. I would like to talk about the PECUNIA care atom and the costing concept, which is the underlying concept of all our 3.5 years of work in the PECUNIA project. The presentation is jointly done by colleagues from SciCost, Loyola, and the Medical University of Vienna. This was the first step in our program of 42 months now. And the main reason for spending a lot of months at the beginning of this project on this concept was that we tried to tackle the existing issues with costing in economic evaluations and the gap between health services research and health economics. The main problems when assessing services are transferability and terminological variability. This means that the names of the services often do not reflect their main activity. For example, if we say hospital or home assistance, this can mean very different things depending on which country we are, in which mental health policy the country is using, and what intensity of care is provided. This can lead in terms of terminology to vagueness, which is under specification of the term, and ambiguity, which means that the term is imprecise and can mean different things. And we will hear more about this in the last presentation of this session. This overall leads to issues with commensurability and the fact that very often in economic evaluations, currently we are comparing apples and oranges and not apples with apples. We use different units of analysis. Sometimes we cost and include services, but sometimes interventions and activities, sometimes single professionals. And often the relevant unit cost and don't match, and we do not follow harmonized comparable costing. So we went back to the basics. We went back to the process of care by Donabedian and the organizational economics rules. We focused in PECUNIA on the micro level at services, and we looked at the inputs, the resources that go into producing care, the throughputs, the processes, the activities that are done by a certain service provider, and the outputs or outcomes, which are intangible consequences or tangible consequences. And you can see relevant examples for all levels. This led to the PECUNIA care atom concept finalization in 2019. We first developed the PECUNIA care atom for services. Here we focused again on the input, and we used international coding systems to move away from language and help comparability and harmonization. Again, there will be more information about this in the following presentations. For unit cost of services, this is really the important part of the care atom. When we are asking patients about their resource use or look at notes and administrative records, by resource use management, we are actually measuring the activity, the throughput of an organization. And what we notice that very often when we talk about the cost of lost productivity or the cost of vandalism, we are actually talking about the cost of some consequences. And these were addressed in some work packages of PECUNIA, focusing on employment and lost productivity and criminal justice and employment. Overall, all of this leads to societal outcomes, the impacts which very often in economic evaluation we would like to try to measure in monetary terms. But of course, it's not just organizational input that goes into care, but also personal resources, time and money. So we developed a similar PECUNIA Keraton for personal resources, and this was the main focus of our work package 4, which is on patient, family, and informal care. Overall, the PECUNIA harmonization concept had 4 main stages. First, the identification of services via literature search and country reports. This will be covered in presentations 2 and 3 today. The definition of services via disambiguation and usage of international coding systems. This will be covered in presentation 4. And this is really the main point of moving away from languages and tackling the initial issues I presented earlier. Eventually, we developed a resource use measurement instrument, which is based on harmonized clusters of services, using these coding clusters we identified in PECUNIA. And finally, the valuation of reference unit cost based on the typology by the PECUNIA coding system and harmonized costing templates based on the PECUNIA Keraton. In summary, this is a new conceptual framework starting from the basis, but it's applicable for any type of economic evaluation across countries and sectors. We developed, based on this, all the PECUNIA harmonized compatible methods and tools. The results are generalizable beyond mental health and can be used in any disease area. And by doing this, we still didn't achieve full societal perspective, but there is a potential for extension for the methods beyond the sectors we covered in PECUNIA. Thank you very much. And I look forward to any questions or contacts via email.
Okay, hello everybody again. In the next 5 minutes, I will present you details on the PECUNIA concept for the harmonized identification of services and resources in mental health care. In this task, we aim to identify resources and services in mental health care that are relevant for economic evaluations. The results of this task were the starting point for the development of the PECUNIA questionnaire for resource use measurement and the corresponding unit costs for monetary valuation. Thereby, it was a general principle that the identification process should be standardized between the project partners. In general, the process of service identification followed 3 major steps. In the first step, sector-specific international systematic literature searches were conducted, followed by country-specific gray literature searches in the second step. The results of both searches were combined to a list of services, which was in the third step sent to national experts for feedback. After inclusion of the expert feedback, the resulting first list of international sector-specific service items was then used for all following working steps. In particular, the drafting of country reports, an example will be shown to you in the next presentation, and for the service definition, which will be introduced to you in the final presentation of this session. Now, let me give you some details on the single steps. The international systematic literature search was sector-specific, cost sector-specific, and cross-country, and focused on cost of illness studies and cost-effectiveness analysis in mental disorders. It was conducted by those partners who were responsible for the respective cost sector of interest, and those partners also defined the specific search strategies, inclusion and exclusion criteria, and relevant databases. After the systematic search, an additional manual search for relevant existing resource use questionnaires and further key papers was added. In a second step, and now country-specific and cross-sectoral, gray literature search was conducted by the partners responsible for a specific country. For example, we as the German partners were responsible for the gray literature search for Germany. The sources to be searched differed from country to country and included, amongst others, clinical guidelines, PhD theses, publications by the government or relevant national organizations, and other online sources. The final step of the identification process were country-specific and cross-sectoral expert reviews among national experts for mental health economics or mental health services research. For this purpose, the results of steps 1 and 2 were combined to a preliminary item list, which was presented to the experts as an Excel spreadsheet containing questions regarding the clarity and accuracy of the items and the item definitions, the relevance and completeness, and also the existence of items within the national context. To finish my presentation, I would like to mention two major problems or lessons learned which we were faced with. First, we realized that we should have defined first what we actually mean by a service, which we didn't. And as a result, we came up with a very long first list containing everything from interventions to treatments, part of services and services. And so we had to define ex post what we actually mean when we talk about services, and the involved partners had to work through the first list item by item to check whether it was a service or not, which was not only very time consuming, but also sometimes really challenging. So the question, what is a service, was really important. A second lesson learned, as Judith has already mentioned, was that language often fails to adequately describe a service because words can have very different meanings in different countries. For example, such a simple thing like a psychiatric hospital stay, which seems to be clear for everybody, can in fact define quite different processes in different countries, which becomes, of course, relevant if you want to calculate internationally standardized unit costs. But you don't realize this until you try to explain such a service to somebody else who then realizes that he or she has something completely different in mind when talking about this service. And with this, I end my presentation and I welcome questions or emails. Thank you.
I am Natasha Peric, and I will use the next 5 minutes for presenting joint work of my colleagues from the Medical University of Vienna, being Claudia Fischer, Susanne Meyer, and Judith Simon, and the rest of the PECUNIA group on how we established a comprehensive list of mental health-related services and resource use items in Austria. So the collection of such items followed an iterative process as described previously in the presentation by Alexander Konopka, with the aim to establish 4 item lists across 5 sectors. So having performed first 5 systematic literature reviews for each sector in a first step, 6 further reviews of the grey literature from each PECUNIA country provided more national level information on potential items, which led to the compilation of the preliminary international sector-specific item lists. And in a final step, the national experts were invited as part of a multinational expert survey to critically assess each preliminary item list according to 4 criteria. So overall, the first and the second step resulted in the inclusion of a total of 295 preliminary international sector-specific items for assessing the consequences of mental health-related interventions in Austria for those sectors that you see listed here. You can see that the majority of items, so 201, was for the health and social care sector, where almost 1/3 came from the national grey literature. They were grouped into inpatient, outpatient, cross-categorical, meaning both, and non-medical costs for social support. A total of 35 items were included in the list for criminal justice sector, grouped as costs incurred as a consequence of crime and costs incurred in response to crime. And 39 items for the education sector, which were grouped into tangible and intangible intersectoral costs and benefits. And the final list for the patient, family, and informal care sectors resulted in a total of 20 items grouped into 4 categories, being informal care, services, goods, and others. In the third step then, so the external review, a total of 18 Austrian experts completed the country-specific Austrian expert survey. The majority of these experts were based in Vienna and represented various stakeholder groups such as patient organizations, healthcare professionals, being psychiatrists mostly, service providers, health insurance funds, policymakers, and federal state authorities. And in terms of clarity and accuracy, a total of 261 items and descriptions were considered clear by all experts. Overall, then, 111 items were prioritized regarding the relevance in the national context, so they had a high frequency use. And 13 items were suggested to be added to accommodate for Austria-specific features of the individual sectors, and a total of 42 items were considered as not existent in Austria by at least one expert. Overall, the activities performed within the identification step revealed country-specific variations across all sectors that call for further systematic investigation. And some points that are specific to the Austrian context were that list of items had to be adapted actually prior to the expert survey to differentiate for care, for the different care settings, being, for instance, outpatient specialist services. Also, the lack of administrative data hindered a data-driven assessment of the economic relevance of the listed health and social care items. And there was also a considerable variation in the prioritization of items regarding the individual economic importance by the experts. And we also observed that significant language barriers, as mentioned by Alexander Konopka, occurred also in the inpatient, family, and informal care sectors, where experts preferred to fill out a translated German language survey instead of the English one. But this work also revealed important general points that are relevant for comparative assessments across countries within the European context, where the separation of health and social care item lists is actually extremely challenging. We further also experienced major difficulties in the differentiation of services and interventions based on item names that suggest considerable underlying typological problems, so both also in the literature and by the experts. And finally, the great imbalance in number of items and in the feasibility of finding sector-specific experts between health and social care and criminal justice and education sectors confirmed the need for additional mapping of the latter sectors for health-related services. With this, I would also like to thank you for your attention, and please reach out via email if you have any further questions. Thank you.
Good morning. My name is Mencia Ruiz. I am a member of Partner 7, CICOST in Spain. Today, I'm going to present the main results of the disambiguation analysis. This was carried out through the definition of identified items using standard classification systems. Systematic and scoping reviews were conducted to identify standard methods for the evaluation of services in mental health. Standard classifications are essential to overcome problems related to terminological variability and commensurability that were mentioned before in earlier presentations. In this sense, the SDLTC classification system for evaluation and classification of services for long-term care provides with a taxonomy of the service delivery across sectors with a glossary of terms internationally agreed and a multi-axial system for coding types of care that is compatible with the family of tools developed by the World Health Organization. With this system, we first identify the minimal unit of production of care that is called the basic stable input of care or care atom. And second, we label them with a code according to its main type of care. The SDLTC uses a multi-axial coding system for the clarity in the definition of terms. In the example presented, the code thread refers to the service type called Assertive Community Treatment Team in the Basque Country in Spain. The first axis includes a code to define the age for whom the service is intended. In this case, it's adults. The second axis includes a code for the diagnosis group according to ICD-10, in this case, mental health. The third axis includes the specific code of the service type. There are 6 main branches that describe the type of care: residential, day, outpatient, self-help support, information and assessment, and accessibility to care. In this case, it's outpatient care. And finally, the additional qualifiers or extension codes describing particularities of the services, in this case, home care. During the PECUNIA project, an operational description of different sectors of clusters of human services were added for health, social, education, criminal justice, employment, and informal care. The SDLTC can be also used in combination with other international classifications like ISCO for describing professionals and ICHI for interventions. The scientific and grey literature reviews carried out, as well as expert surveys gathered for the identification of items by our colleagues, showed a variability of local terms that required a disambiguation based on the agreement of an international consensus definition, the SDLTC in this case, for the coding of the care atom. Codified items were then classified into the following categories: accurate, when the item could be classified using only one code; ambiguous, when the item was labeled with more than one code; and vague, when the item only could be coded with a series of codes; and confusing, when the term was wrong or it required additional significant interpretation from experts. Definitions provided by the classification system can be then back translated to local language to be used by experts. A list of 56 items were disambiguated for the health and social sectors, of which 34 corresponded to the health sector and 22 to the social sector. Terms and definitions were analyzed at different levels. First, unit of analysis tried to differentiate services from other units like procedures, interventions, or professionals. In this case, 50 items representing the 89% were classified as accurate and 6 as confusing. For example, there was an item called legal carer that actually referred to a professional and not to a service. At level 2, we gathered information on the target population for which the service was intended, including age and diagnosis group. 52% of the items were considered accurate, 3 confusing, 4 ambiguous, and 20 items representing the 36% were vague. For example, the item rehabilitation facility that was intended for people recovering from illness, injury, or addiction included very different and not well-defined target populations. And finally, level 3 of disambiguation included definition of the service typology using the main types of care of the DESDE. 41% of the items were rated as accurate, 11% confusing, 21% as ambiguous, and 23% as vague. Following the previous example, a rehabilitation facility that was described for different populations could be coded as residential, day, or outpatient care, including a wide variety of coding possibilities. This would be the main results. Thank you for your attention, and I look forward for any questions you may have.